Welcome to the MS-Perspektive podcast, Perspektive with a K as I'm German. I'm Nele von Horsten, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins. Thanks for tuning in again and welcome to episode number 74, S1P receptor modulators, Fingolimod known as Gilenya, Ozanimod known as Zeposia, Ponesimod known as Ponvory and Siponimod known as Mayzent for active relapsing MS and secondary progressive MS. Today it is all about the group of S1P modulators, which includes Fingolimod Gilenya, Ozanimod Zeposia, Ponesimod Ponvory and Siponimod Mayzent. The first three, i.e. Gilenya, Zeposia and Ponvory, are used as a disease-modifying therapy for active multiple sclerosis. Fingolimod Gilenya is even approved for pediatric MS. Mayzent is approved for active SPMS if the patient is already experiencing a worsening of MS independent of relapses, but also has localized inflammatory activity. S1P modulators are pronounced sphingosine 1-phosphate receptor modulators and prevent the leakage of lymphocytes from the lymph nodes. This also prevents them from entering the central nervous system, CNS. The S1P receptor subgroups determine the side effect profile. Please remember that I can only provide an overview here. Your neurologist and your MS nurse should advise you in detail on the right therapy for you. This is because they know your general state of health and you should also talk about your goals, wishes, fears and preferences so that these can be taken into account. As usual, I start off with the general information. To get a good overview of the major topic of therapy decisions, I recommend that you first listen to episode number 58, Immunotherapy in MS, a guide to efficacy and choice with Professor Dr. Tjalf Siemsen. There you will find out why you can only compare the various disease-modifying drugs to a limited extent, why it is important to start an effective therapy quickly, why MRI and other examinations are important for assessing progression and provide information about effectiveness, why therapies should be changed as little as possible, but of course if they are not effective enough, why in most cases it is better to start with a highly effective therapy and only switch to a lower category at an advanced age, why in the case of highly active MS it may be more important to start immunotherapy quickly and tackle rehabilitation as a second step, why generics and biosimilars are being used more and more and which approval requirements they have to fulfill, why the risk and side effects of a therapy must be differentiated into unpleasant side effects at the start of therapy and rare possible risks, and these must be set in relation to the usually irreversible effects of untreated MS in the long term, why it is important to honestly discuss your opinion, wishes, goals and fears with your neurologist in order to make treatment decisions together that both sides can agree on, why it is advantageous to be cared for by MS specialists and to stay informed yourself in order to benefit from new findings and treatment options, and why it makes sense to contribute to a favorable prognosis with your own healthy lifestyle. Another general note, the approval studies for the individual drugs were carried out at very different times. 30 years ago, you had to be more severely affected or more advanced in the course of the disease to receive a reliable diagnosis of multiple sclerosis. Less severely affected people were probably not diagnosed or not diagnosed at first. With ever-improving examination methods such as MRI, even small lesions in the central nervous system can now be seen better. Furthermore, 30 years ago it was not yet known that neuromyelitis optica spectrum diseases, NMOSD for short and MOGAD, are separate diseases that require their own therapies and sometimes even react negatively to MS medication. They were previously thought to be multiple sclerosis and MS therapies did not alleviate the disease activity. How are S1P modulators, Fingolimod Gilenya, Ozanimod Zeposia, Ponesimod Ponvory and Siponimod Mayzent classified in immunotherapies? There are currently 3 different therapeutic approaches for the preventive, i.e. disease-modifying therapy, DMT, of multiple sclerosis. The most unspecific is immunomodulation. Migration inhibition already narrows down the path, which also includes Fingolimod, Gilenya, Ozanimod, Zeposia, Ponesimod, Ponvory, and Siponimod, Mayzent. And the most specific is the depletion of immune cells. The DMTs are listed in alphabetical order. Number 1, immunomodulation. The therapies weaken the immune system. They have a very broad effect via various factors, e.g. on Th1, T17, Th2, T regular, and antigen presentation, as well as on different signaling pathways and possibly via other mechanisms. They attempt to shift the milieu from inflammatory to non-inflammatory. Dimethyl fumarate with Tecfidera and generics and diroximel fumarate with Romarity belong to it, as well as glatiramer acetate with Copaxone and generics, interferon beta with interferon beta 1a, Avonex and Rebif, interferon beta 1b with Betaferon and Extavia, and PEC interferon beta 1a with Plagridi, and teriflunomide with Obejio. Number 2 is migration inhibition. The migration of certain immune cells is inhibited. Natalizumab with Tysabri and Churuco belong to it, as well as the S1P modulators, which are the topic of today with Fingolimod, Gilenya, Ozanimod, Zeposia, Ponesimod, Ponvory, and Siponimod, Mayzent. And then there's the third category with cell depletion. Developing immune cells die off with depletion of T cells, B cells, natural killer cells, and monocytes with alemtuzumab, known as Lemtrada and Kempes, T and B cell depletion with cladribine, known as Mavenclad, Loistat, or Litakine, and B cell depletion with ocrelizumab, known as Ocrevus, ofatumumab, known as Kesimpta or Bonspree, rituximab, known as Meptera, Rituxan, and ublituximab, known as Briumvi. What are Fingolimod, Gilenya, Ozanimod, Zeposia, Ponesimod, Ponvory, and Siponimod, Mayzent approved for? Let's start with Gilenya. Fingolimod is approved for the treatment of highly active forms of RRMS that progress rapidly. It can be used in pediatric patients aged 10 years and older. The German Multiple Sclerosis Competence Network, KKNMS for short, recommends its use in patients who have already received another disease-modifying treatment and still have a high disease burden after a sufficient startup period, or for patients who have not yet received DMT but have a severe form of relapsing remitting MS defined by 2 or more relapses with worsening disability have occurred within 1 year, and MRI of the head shows at least 1 new gadolinium-enhancing lesion or a relevant increase in T2 lesions compared to a recent MRI. In other words, an existing inflammatory activity is detectable. Different information or recommendations are possible from country to country. Let's move on to Ozanimod, Zeposia. Ozanimod is approved for the treatment of active forms of relapsing MS in adults. Participants in the approval studies had to have at least 1 relapse in the last 12 months, or a clinical relapse in the last 24 months, plus at least 1 active lesion that absorbs contrast media on MRI in the last 12 months. Over 2/3 of patients were treatment naive. New T2 hyperintense or increasing T2 hyperintense lesions are also considered MRI activity. Let's come to Ponesimod, Ponvory. Ponesimod is approved for the treatment of active forms of relapsing MS in adults. Participants in the approval studies were included if they had an EDSS score between 0 and 5.5 with at least 1 relapse in the last 12 months, or 2 relapses in the last 2 years, or 1 active lesion that absorbs contrast media on MRI in the last 6 months. Based on the criteria of the pivotal study, Ponesimod can therefore also be used for SPMS with superimposed relapses in addition to RRMS. However, there were no explicit SPMS studies. Siponimod, Mayzent. Siponimod is approved for the treatment of active secondary progressive MS that show inflammatory activity. Clinical or MRI activity is defined by relapses within the last 2 years, MRI activity with new or enlarging T2 lesions and or contrast-enhancing lesions in a recent MRI, maximum 3 months old. In the EXPAND pivotal study, only the presence of contrast-enhancing lesions at baseline could be considered due to the study design. The KKNMS recommends that new or enlarging T2 lesions, compared to previous images within the last 2 years, should also be evaluated as MRI activity. The FDA approved Siponimod to treat adults with relapsing forms of multiple sclerosis to include clinically isolated syndrome, relapsing remitting disease, and active secondary progressive disease. Different information or recommendations are possible from country to country for all these 4 substances. What is the situation for special patient groups? Let's start with teenagers and children. Fingolimod, Gilenya, is the only S1P modulator that is officially approved for usage in children 10 years and older. The Paradigm study compared Fingolimod to interferon beta-1a, and Fingolimod lowered the annual relapse rate by 82% and the number of new or enlarged lesions on T2 weight MRI by 53%. Both numbers are relative difference. For an individual consultation, please contact an MS specialist, preferably a neuropediatrician. Let's move on to pregnancy and breastfeeding and the recommendation of the European EMA and American regulatory authorities FDA. S1P receptor modulators should not be used during pregnancy or if there is a desire to have children. Women of childbearing age should use safe contraceptives during S1P receptor modulator therapy. Women should not breastfeed while taking S1P receptor modulators. The FDA also warns of a severe increase in disability after discontinuation without alternative therapy. Recommendation of the DMSKW, the German MS Fertility Register, which is based on the current data situation and experience of the DMSKW. All 4 active substances are taboo for women of childbearing age who are not using safe contraception, and contraceptive protection must be maintained for the entire duration of treatment. A negative pregnancy test is required before starting treatment. Fingolimod Gilenya harbors a teratogenic risk that continues to have an effect for 2 months after the end of therapy. Therefore, an interval of at least 2 months must be observed before a pregnancy can be planned. For the newer drugs Ozanimod, Zeposia, Siponimod, Mayzent, and Ponesimod, Ponvory, there is not yet sufficient data available, but here too a teratogenic potential is possible. The active substances are broken down at different rates in the human body. This results in different safety margins for the onset of pregnancy. For Ozanimod, Zeposia, this interval should be at least 3 months. For Fingolimod, Gilenya and generics, at least 2 months. Siponimod Mayzent, on the other hand, only needs to be discontinued 10 days before a planned pregnancy, and Ponesimod Ponvory only 1 week before. If a pregnancy nevertheless occurs with one of the active substances, the therapy must be terminated. More intensive ultrasound diagnostics should be carried out as a precaution. After discontinuation of therapy with Fingolimod, Gilenya and generics, there may be increased disease activity. Sometimes severe relapses can occur after discontinuation, leading to disability. The same effects may occur after discontinuation for the other 3 drugs, Ozanimod, Zeposia, Siponimod Mayzent and Ponesimod Ponvory. There is not yet sufficient data on this. Pregnancy should therefore be planned carefully, and if necessary, therapy should be changed. Alternatives may include anti-CD20 antibodies, Mabcera, Truxima, Rixacton, Ocrevus, Kesimpta, Cladribine, Mavenclad, or Natalizumab Tysabri. After birth, if breastfeeding is not taking place, treatment can be continued with S1P receptor modulators. S1P receptor modulators should not be used for breastfeeding as the drug is very likely to be absorbed by the infant via breast milk and the risk to breastfed children has not yet been ruled out. Who should avoid Fingolimod, Gilenya, Ozanimod, Zeposia, Ponesimod Ponvory and Siponimod Mayzent? Patients with myocardial infarction, unstable angina, stroke, circulatory disorders of the brain, severe heart failure currently or in the previous 6 months, cardiac arrhythmia, or other diseases of the heart or cerebral vessels. Patients with moderate or severe hepatic insufficiency, patients with severe active infections and patients with chronic infections, especially hepatitis B and C, and tuberculosis. Immunocompromised patients, patients with malignant diseases including skin cancer, patients with macular edema, the accumulation of fluid in the area of the yellow spot of the eye. Due to the increased incidence of macular edema, particular caution is required in the context in diabetics and patients with uveitis. Patients with hemophagocytic syndrome, a highly inflammatory disease of the immune system or a mutation associated with it. Patients with severe respiratory disease, pulmonary fibrosis or chronic obstructive pulmonary disease, COPD. The severity of the problem might vary between the 4 different S1P modulators. How do Fingolimod, Gilenya, Ozanimod, Zeposia, Ponesimod, Ponvory, and Siponimod Mayzent work? S1P prevents lymphocytes from leaving the lymph nodes and thus from migrating into the central nervous system. Immune cells are not destroyed but only imprisoned. Th17, naive T and B cells, and central memory T cells, TCM, in particular are retained. Effector memory cells, TEM, can continue to function normally. There are fewer pro-inflammatory cells in the blood system. Effect occurs very quickly. Within hours of ingestion, the number of lymphocytes decreases and, depending on the specific S1P modulator, reaches its lowest point after a few hours to a month. This is 20 to 30% of the initial value. The process is reversible. When the therapy is stopped, the lymphocytes can migrate again. However, it can take a long time for everything to return to normal after prolonged treatment. This causes problems when changing therapy, and there is a risk of rebound, i.e. a strong return of disease activity. How quickly everything normalizes after you stop taking the drug depends on the specific active ingredient and ranges from a few days to a month and a half. However, it can also take longer. S1P receptor subgroups determine the side effect profile. Fingolimod binds to 4 of the 5 sphingosine 1-phosphate receptors, S1P1, S1P3, S1P4, and S1P5. Ozanimod binds primarily to the sphingosine 1-phosphate receptors S1P1 and S1P5 with a 10-fold preference for S1P1. Ponesimod binds to the S1P receptor. Siponimod binds to 2 of the 5 sphingosine 1-phosphate receptors, S1P1 and S1P5. Fingolimod, Ozanimod, and Siponimod cross the blood-brain barrier. The significance of the effect on the cells of the central nervous system is not yet fully understood. How is it taken? The capsules can be taken with or without food. Dose adjustments according to weight, gender, or ethnicity are not usually made in adults. No dose adjustment are necessary for mild to moderate hepatic insufficiency. Fingolimod, Gilenya, and generics. Fingolimod is taken orally as a 0.5 mg capsule once a day. In children from the age of 10, a Fingolimod dose of 0.5 mg once daily is recommended if the body weight is over 40 kg. Up to a body weight of 40 kg, 0.25 mg should be administered once daily. Ozanimod, Zeposia. Ozanimod is taken orally as a capsule once a day. The dosage must be increased slowly. Day 1 to 4, 0.3 mg once daily. Day 5 to 7, 0.46 mg once daily. From day 8, 0.92 mg once daily. Maintenance dose. Ozanimod is contraindicated in severe hepatic impairment, Child-Packs. Renal impairment does not require a dose adjustment. No pharmacokinetic data are available for children and adolescents under 18 years of age and for patients over 55 years of age. Ponesimod, Ponvory. Treatment must be started with a 14-day pack to initiate treatment. Treatment starts on day 1 with the intake of a 2 mg tablet. The dosage regimen is as follows. Day 1 plus 2, 2 mg. Day 3 plus 4, 3 mg. Day 5 plus 6, 4 mg. Day 7, 5 mg, day 8, 6 mg, day 9, 7 mg, day 10, 8 mg, day 11, 9 mg, day 12 to 14, 10 mg, and since day 15, 20 mg. After completion of dose titrations, the recommended maintenance dose for Ponesimod is 20 mg tablet once daily. Siponimod, Mayzent. In order to adjust the dosage individually, it is necessary to determine the metabolization status by testing the CYP2C9 genotype before starting therapy with Siponimod. In the Caucasian population, approximately 10% of patients have a polymorphism that leads to moderately rapid metabolization. Slow metabolization is present in approximately 0.5% of patients. In patients with normal metabolization, Siponimod is administered at 2 mg once daily. In patients with intermediate metabolization, Siponimod is administered at 1 mg once daily. And in patients with slow metabolization, a different drug should be chosen. The dosage is administered according to the scheme. Day 1 plus 2, 0.25 mg. Day 3, 0.5 mg. Day 4, 0.75 mg. Day 5, 1.25 mg. And day 6, 2 mg for normal metabolization and 1 mg for intermediate metabolization. Single dose phase. If a titration dose has been missed for more than 24 hours, a restart at day 1 is necessary. Intake phase after reaching the target dose. If Siponimod has not been taken for 4 or more consecutive days, a new dosing is necessary. How effective are Fingolimod, Gilenya, Ozanimod, Zeposia, Ponesimod, Ponvory and Siponimod Mayzent? Gavin Giovannoni, an MS expert from the UK, has graded his MS selfie cards on a scale of 1 to 10, with 1 being low efficacy and 10 being maximum efficacy. In his estimation, all 4 S1P modulators score 5 for preventing relapses and 5 for avoiding long-term disability. In the pivotal study, Fingolimod led to 54% fewer relapses and slowed disability worsening by 30% compared to placebo. In other words, you can also look at 100 patients. 46 of these patients remain relapse-free even on placebo. In the Fingolimod group, a further 24 patients remained relapse-free. Looking at the same 100 patients, 76 remained at the same level of disability as measured by the EDSS, the Expanded Disability Status Scale, during the pivotal trial period, including the placebo group. 6 people in the placebo group deteriorated who remained stable in Fingolimod. Ozanimod was compared to beta interferons and reduced relapses by 38%. The influence on the disability progression is not yet clear. Ponesimod was compared to teriflunomide and reduces relapses by 30%. It is as effective as slowing disability progression. Compared to placebo, Siponimod reduced relapses by 46% and slowed disability worsening by 37%. Risks and side effects of Fingolimod, Gilenya, Ozanimod, Zeposia, Ponesimod, Ponvory and Siponimod Mayzent. Typical side effects for Fingolimod are: more than 1 in 10 get diarrhea and headaches, varicella zoster virus, shingles and herpes simplex increased, cryptococcus, progressive multifocal leukoencephalopathy, PML risk much lower but present, basal cell carcinoma, macular edema. Typical side effects for Ozanimod are headaches, increased infections, increased levels of liver enzymes, varicella zoster virus, shingles rarely. Typical side effects for Ponesimod are increased levels of liver enzymes, swelling in part of the retina, basal cell carcinoma. Typical side effects for Ponesimod are headaches, reduced white blood cells, basal cell carcinoma. What are the safety precautions and lab parameters? Clinical neurological checkup. Clinical neurological checkups must be carried out quarterly. Basic laboratory program. Routine laboratory parameters, blood count plus differential blood count, must be checked 2 and 4 weeks after the start of treatment. Thereafter, laboratory checks are necessary every 3 to 6 months. In the event of lymphopenia below a defined value, which is confirmed in a second measurement after 2 weeks, Fingolimod, Ozanimod, Ponesimod and Siponimod must be discontinued. A differential blood count must then be performed at 2-week intervals, and the medication can only be restarted when the absolute lymphocyte value is above the defined limit. If lymphopenia occurs repeatedly, a dose reduction may be considered in individual cases. The dose of Siponimod can be regularly reduced from 2 to 1 mg. When treatment is restarted, the dose must be increased again. Lymphopenia occurs with all S1P receptor modulators, which shows that the substance is effective. The tests are therefore only concerned with ensuring that the levels do not fall too low. Some patients react very strongly to the therapy, which is why the regular checks are very important, especially in the early stages, in order to be able to react, if necessary, until the body has become accustomed to the medication. With all S1P receptor modulators, the liver values must be checked shortly after the start of treatment and then at 3 to 6 months intervals. If certain liver values increase, weekly checks must be carried out. If defined limit values are repeatedly exceeded, the medication must be permanently discontinued. Radiologically monitoring. An MRI of the brain should be carried out once a year to assess the success of the treatment and to assess possible complications of the therapies that are relevant for differential diagnosis. Contrast agents are only necessary if there are indications of a worsening of the disease or if there is no standardized initial MRI. Ophthalmologic control. Patients with diabetes mellitus, uveitis, or known retinal disease should be examined by an ophthalmologist before starting therapy and undergo regular checkups during treatment. With Ponesimod, all patients should also have an examination of the back of the eye, including the macula, before starting treatment. The eye examination after 3 to 4 months of Fingolimod therapy checks for macular edema. The fundus of the eye must be examined, alternatively an OCT as a supplementary examination, if visual disturbances occur during treatment with one of the 4 S1P receptor modulators that cannot be attributed to opticus neuritis. Dermatological control. Due to the increased incidence of basal cell carcinoma with S1P receptor modulators, a dermatological checkup is recommended 1 year after the start of treatment and then every 6 months for patients at risk. Pulmonological checkup. If there are indications of pulmonary dysfunction, a specialist pulmonological examination should be carried out. Cardiological checkup. During treatment with Siponimod, blood pressure should be checked after 3 months and then annually, and high blood pressure should be treated accordingly if necessary. On the MS selfie card mentioned earlier, the side effects are rated on a scale from 1 for few or rare to 10 for many or frequent as follows. Regular side effects at 3 for Fingolimod and Siponimod and 4 for Ozanimod and Ponesimod. Long-term side effects at 5 for all 4 substances. Cancer risk at 7 for Fingolimod and Siponimod and at 6 for Ozanimod and Ponesimod. All 4 S1P modulators receive the following rating in the MS selfie card overview of the effects of therapy. Clinic visits, moderate. Family planning, short-term incompatible. Vaccinations, poor response. Let's talk briefly about vaccinations. Before starting treatment with Siponimod Mayzent, patients must be tested for varicella zoster (VZV). VZV seronegative patients must be vaccinated against VZV, so shingles, before starting treatment. Treatment with Siponimod can be started at the earliest after vaccination. The effectiveness of vaccinations may be limited during therapy and up to 2 months after discontinuation of Fingolimod, Ozanimod, Ponesimod and Siponimod. If necessary, the vaccination success should be checked by means of titer control. Live vaccines should be avoided and only administered after a thorough risk-benefit assessment. All other vaccinations are permitted during treatment with S1P receptor modulators. Vaccination against herpes zoster, which leads to shingles, is recommended for patients with immunotherapy from the age of 50. In this case, vaccination with the inactivated Shingrix vaccine is recommended. Sources. I used the following sources to create the content. Lecture on S1P receptor modulator by Professor Dr. Tobias Derfus as part of the Multiple Sclerosis Management Master's Program. Quality Manual of the German KKNMS on Fingolimod, Gilenya, Ozanimod, Zeposia, Ponesimod, Ponvory and Siponimod Mayzent. MS Selfie Info Cards by Professor Dr. Gavin Giovannoni. German Multiple Sclerosis and Fertility Registry, DMSKW. Information from the German interview with Professor Dr. Barbara Kornick on pediatric MS, and the German DSIMS information on Fingolimod. One final note. Please remember there is no one great medication that helps everyone, but it must always be weighed up what suits a particular person best. Other illnesses, personal goals and preferences must also be taken into account. Your neurologist and MS nurse are the right persons to talk to and can make individual recommendations. This article is for information purposes only and does not constitute a recommendation. What helps one person may not help another. I hope that together with your neurologist and MS nurse you will quickly find the right immunotherapy for you, and that you can lead a fulfilled, happy and self-determined life with MS, supported by a healthy lifestyle and a dose of fortune. By the way, you may also want to look at the other podcasts on the other DMTs. You will find the information in the show notes. By the way, next time I will be talking about decoding the EDSS score, how it's measured and what it means. And even so, the EDSS score is not perfect, as it is not granular enough and not taken into account things as fatigue. It still has its values. So tune in again and learn more about the EDSS score. And as always, if you know somebody who might be interested in the podcast, please recommend it to that person and give a ranking wherever you listen to the podcast. And of course, write me an email if you have questions or suggestions for other podcast episodes. So please stay as healthy and positive as possible, and see you next time. Bye. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.